It's my pleasure to introduce Professor Mian Mikalo from Red Cross War Memorial Children's Hospital, Cape Town, South Africa. And she'll talk about does treating AKI in low-resource regions matter?
Good morning, everybody. I'd really like to thank Ravi and the team for inviting me to come as a pediatrician and someone from a long way away. I also really want to thank the audience for getting up this morning, not going outside in the lovely sunshine and actually coming and listening to this talk. So thank you for a very interesting topic. I wasn't quite sure how to address that, but let's see what we can do. So does it really matter? I've asked some of my fellows, and I'll show you a picture in a minute. No disclosure except that I am very passionate about pediatric care for AKI in low-resource settings. This is a picture of yesterday with World Kidney Day of our team celebrating, and even our barista made a kidney-shaped coffee for everybody in the hospital. I am the chair of the next IPNA Congress in Cape Town, so I have to advertise that. Abstracts are open, so put in your abstracts. And I was really glad that one of the previous speakers gave us a little glimpse of where they work, because I think I need to just explain to you where I work. It's a children's hospital, standalone, 300 beds. We have the biggest intensive care unit for children in Africa, 30 beds. We see about 1,400 admissions, which when you stand here in front of adults, it seems little, but kids take a long time. Putting up a drip can take you 4 hours. In the renal unit, we have 12 beds. We do solid organ transplants, not many, but we do enough. And we have a whopping 3 pediatric nephrologists who do all this work. We clinicians, we work in a state hospital. We don't do any private practice. And we do try and get some clinical research done, but I'm always really a little in awe of people who do scientific and bench research. I don't grow any glomerular basement membrane in petri dishes, so sorry about that. When I asked my team, so Wally from Botswana, Dati from Nigeria, Ithwako Pocket Rocket from Malawi, and Nana from Ghana on the right-hand side, as well as my team and a young lady from Germany, whether they thought it was important to treat AKI in under-resourced countries, this was their answer. So we know that there have been substantial developments in kidney replacement therapy, even for the smallest neonate. We are quite sophisticated, so we have got multifiltrate machines. We've had a carpe diem for about 7 years already. We do call a lot of friends. It's quite a technically demanding machine. We've gone down to doing CVVH on 1.7 kilogram babies, so we do quite well. But we are a PD first for pediatric acute kidney injury, and we do acute start. So we put in PD catheters at the bedside by non-surgeons. I'll show you some research. And we can get that done in 17 minutes from the child arriving in the ICU. It takes us a much longer time to get CVVH going. But the problem is that many low and middle income countries don't have access to the facilities that we do. So we're very aware of that. I stole the slide from Daniela Serrana. Green is good. Grey is not so good or unknown. Light green is not great. So really important that there are often not surgeons available even in these countries. And this is a paper that we published a few years ago saying that AKI in approximately 13.3 million people, 85% in low resource settings. And actually we don't know because there are just not systems in place to actually assess what the burden of AKI is. This is a stunning paper from Nigeria, which looked at sub-Saharan Africa and a systematic review. I've looked just at pediatric studies on the right-hand side. Mortality for AKI, roughly 30%. Mortality without dialysis, when you need dialysis, up to 90%, which is hardly surprising. If you need dialysis and you can't get it, you are going to die. And mortality with dialysis, still 34%. So this is in children, slightly better in adults. And this for me is an iconic slide. Many of you will know Tim Bunchman, who is from the US, Stefano Picco, who's from Italy, has worked with Claudia Ronca, and my own colleague Pete Norse, doing continuous flow PD research by gravity. So I'll talk a little bit later about that. So just the topics I'm going to go through. We've looked at just under 600 patients that we've dialyzed in our center in the last 20 years or so. Most of our kids are quite young, 9 months, or most of them are less than 1 year. Compared to the rest of Africa, the kids are a lot older. What are the conditions requiring dialysis? Often very similar to yours in North America. So we do have open heart surgery, about 400 cases a year, underlying kidney pathology, sepsis and shock. But because we do PD first, about 80% of our kids received PD at average of 6.4 months. The rest, I called it extracorporeal because they got CVVH and some of them got prolonged hemo or a bit of SLED. They're the older kids, so the kids ranging around about 6 or 7 years of age. So for us, a bedside PD catheter on the left-hand side is a lot quicker than waiting for our surgeons. Yes, we have surgeon. Yes, we have 8 operating theatres for children, but it takes time to get the kids into theatre, to put in a proper Tenkoff or a tunneled central line, as you can see in that little baby. So we tend to do PD first at the bedside. Our surgeons are aware of it. We did a review, and you can see that only less than 10% of the cases were inserted by surgeons. The rest were either Cook or peel-away catheters at the bedside. What was the dialysis times? Well, this is the good news, is that if you need to dialyze a child with AKI, 72% of them will need dialysis for less than a week. So you're just trying to tide them over. We're not talking long-term. If it's long-term, it's a whole new ballgame. You then need to look at CKD, and we then do laparoscopic PD catheter insertions and the stuff that you would do as well. Complications, not going to go into it too much, but it's usually blockage or poor drainage or leaking. 2, we put catheters into the bladder because somebody had forgotten to put a urinary catheter in the bladder. And in 22% of the cases, we had to change from PD to extracorporeal. So just the blue is the blockage. Overall survival, so 57.8% overall. Neonates did much worse. Children over a year did much better, which is hardly surprising. And interestingly, PD did much worse than extracorporeal dialysis, but that may be because the children were much harder to dialyze, the ones who got PD. And I think for people who have nothing else available, this is good news in that you are going to be saving more than 50% of the children who may not have access to anything else. So for us, it's slightly different. We've done, this is the dialysis trends over time. Blue is PD, so it seems we're doing less than we used to do. And then the solid dotted line, ECD, is increasing, and that's because I think possibly we've now got the carpe diem or machines that can dialyze smaller children. So in our center, we've become more sophisticated over time, but we are still doing PD. So conclusions: an acceptable survival. Outcomes are poorer in smaller children, which is hardly surprising, but acute PD with bedside catheter placement, placed by non-surgeons, it's feasible, it's practical, and it gives an acceptable dialysis modality. So we really like the PD first in pediatric AKI. Then talking about training doctors, because that's the other big thing for AKI. So this is a paper about our training in Cape Town. Our fellows, we've trained 44 fellows in the last 20 years. They've spent about 2 years with us, and often they've gone back as the only pediatric nephrologist in their country. That has huge implications. I've drawn a little map for you so you can see where all these folks have gone back to. I'm really proud of this work. I would hope one day on my tombstone it would be "she trained," because that's something I really enjoy doing. You may ask, why has Nigeria got so many smiley blue faces? Well, because Nigeria actually has 220 million people in that tiny country. In the US, you have 320 million people in your entire country. So you can understand why we're doing a lot of training for Nigeria. What are we not doing well? Well, unfortunately, half of Africa is French-speaking. I can speak a bit of French, but we need to be improving the French countries in terms of training. We did a quick survey on all of these fellows. 100% of them returned home, which is amazing. And frequently available was adult equipment on the left-hand side. Rarely available was pediatric equipment. So that's really a big problem. And the clinical impact of their fellowship is that they really enjoyed the fact that they got hands-on training. We taught them how to do hands-on PD At the bedside, we taught them to do renal biopsies, and they got lots of practical skills. What are the challenges on return? This is an adult unit in the Cameroon, just can't get fluid easily. And so we actually did a little study on making up locally prepared PD fluid when we couldn't get bicarbonate dialysis for small babies, and our peritonitis rate was only 4%. So we were really very careful about our sterility, and that again is good news as well, in that you can actually make up PD fluid out of Ringer's lactate and you can add some glucose to that. So Heath Robinson, you can improvise using Ringer's lactate, a 3-way tap, a drainage bag, and a nasogastric tube with extra holes if you've got a surgeon to put it in, or else whatever device like a chest drain or whatever else you need. As I said earlier, we're doing some interesting research, my colleague Peter Norse, on gravity-assisted continuous flow PD, great clearances, just putting in 2 PD catheters. As a result of all of this, we've actually put together international guidelines on AKI, not only for kids, but for adults as well. And during COVID, I was phoned by some really top-class units around the world to say, Mignon, we've run out of CVVH machines. Can you remind us how to do PD? So we did this for adults, we did it for peds, and it's really, I think it's a great guideline. If you've got a surgeon, gold standard, go for it. Please don't fire all your surgeons, but if you don't have that, then you need to do bedside. Unfortunately, Cook has discontinued their little PD catheter, but I much prefer the pigtail. So new generation Cook catheters, $120. I haven't heard many people speak about costs at this meeting. For us, that's huge. Really hats off to Daniela and her team for putting together potentially a low-cost PD catheter. My MacGyver practice, 3-way taps can improvise anything, and a Buretrol. You can actually save lives with these. So this is a picture from a little baby, a prem in the Philippines, where they are using adult central lines as PD catheters. Isn't it bizarre that you can get an adult central line anywhere? You can't get a ped central line anywhere, but you can get an adult central line, and so you can actually save a life using an adult central line. Manual dialysis with a fluid warmer is what you can do. There is these kits that are custom made, but we actually often just manufacture our own. Is this low tech? This is a baby who's had open heart surgery at day 3 of life with an oscillator, nitric oxide, a ton of inotropes, and the surgeon has put in a PD catheter to do PD, which is pretty routine in most of the cardiac units around the world. The costs, I don't know if you can see at the bottom, I've converted for you. So carpe diem for us to run a day in our unit, $370. To do manual out in the districts, $26. I don't think you can compare that. So what is the development of PD in low-income countries? And this is a paper we've actually just published last month, the Saving Young Lives program. I'm just going to whiz through it quickly. A couple of organizations, including SFNDT, which is a French organization. We've got a steering committee and very many regional advisors. We have, this is now outdated, we have saved almost 1,000 patients with a 65% survival rate. What do? We go and teach not only about children, but anybody under the age of 90, I think would be considered a young life. So we've actually gone and done training for bedside PD catheters across the world. I've been to Bhutan, I've been to Puerto Rico. It's been a really interesting process. And we've actually trained doctors and nurse teams. So I think my take-home message is never give up. Do detective work and look and embrace new developments. In Africa, it's very hard to order small quantities of stuff because it's really not cost effective for the companies. But I think as we push back and say that children deserve smaller devices, I think it's really important. So we need to campaign for children. I have gone to ministers of health to thank them for supporting AKI in children, knowing that they don't. And then they kind of feel a bit embarrassed and then get onto the platform. I really want to give a big shout out to Dialysis Without Borders. I didn't know about you guys before I came here. I'm really excited about the potential work we're going to be doing. I think your devices are really, really inspirational and really have enjoyed my time in San Diego. So no patient with AKI should die without an attempt of any form of dialysis if they should need it. Do what you do best. please don't go and throw your machines away. Do what you need to do, but if your country, which is high income, becomes a low resource setting because of a natural disaster or a war environment or loss of electricity, no one should die without an attempt at PD. I work in a super sophisticated environment, but I am very comfortable with teaching how to manage in low resource countries. Homemade fluids, improvised catheters, local solution for local problems, and you can make a difference wherever you are. And just a big thanks to my entire team, my nephrology colleagues, my intensive care colleagues, and all the new friends that I've met at this meeting. And thank you for all the wonderful work you all do, and keep it up.